ICD-10 reflects greater clinical detail and will require increased documentation specificity. The big scare with ICD-10 is that our current charts don't support ICD-10, and that is only going to be true if you've done a review of your current documentation and found that it's lacking detail to code in ICD-10. So the biggest change in ICD-10 is laterality. Most of the codes, especially codes for fractures, will have a laterality component where we're reporting left side versus right side. I've never gone through an orthopedic note and not known which side was affected. So as long as you're capturing it's the right leg versus left leg, we should be able to find the correct diagnosis code. Where there may be some issues, and we'll get to this a little bit later, is some of the cause and effect codes for the injuries themselves. Usually because of diagnostics and radiology, we know where the fractures are, we know which limb it's on, we know the bone that's affected, and that will allow you as physicians or your coding staff to correctly assign the right ICD-10 code without any changes to what you're doing today. Where we might have some changes would be in how we're capturing the information about where the patient was when they got injured and how they got injured. So we haven't had changes to ICD-9 since 2011, which means that we have quite a few codes that are being continually added to ICD-10 as new diagnosis codes. The code set itself in ICD-10 will not be updated until 2016. So if you have any ICD-10 coding resource books in your clinic or office, they could be from 2011 till 2015, and they're going to be the same book. We'll be using these same versions until October of next year. October of 2016 will be the first time in about 5 years that we've had an update to our coding system. And that's where the CMS will go through with the CDC and update the codes that required coding. So it could be just corrections, could be revisions, could be clarifying guidelines in ICD-10, but that won't happen until 2016. So when are we going to start using ICD-10? Well, starting with all inpatient discharges that are October 1st or after, and all outpatient claims with a date of service of October 1st and moving forward. We know that most payers, it will be like flipping a switch. Dates of service from September 30th and earlier will be in ICD-9. October 1st on will be in ICD-10. So part of what we talked about in earlier sessions with administrative staff was making sure that your vendors and your EHR systems or the practice management system you're using for data entry can accept dual entry, that they can still work in ICD-9 and in ICD-10. Because as much as we'd love it, we know that moving into October and the rest of the year, we will still be working AR that's in ICD-9. And that will probably continue for the next year or so, that you'll have claims that are still being worked in ICD-9. So being able to edit in ICD-9, submit claims in ICD-9, all of that's things that we'll talk about working with your vendors on. So understanding the impact about who needs to be trained in your office is an important piece. Who do you utilize for coding resources? Does your ancillary staff help input codes in your documentation or in your orders? Do you have a separate billing or coding staff? Are you the one doing charge entry right out of your EHR? So depending on how many people are involved in that claims process will help determine what kind of education is required. It will also help you understand how many other systems or products are utilized that will need to be referenced for your vendors to make sure that ICD-10 implementation is going to go smoothly with those vendors. If you're updating things like encounter forms or super bills, if you still use those for charge entry, modifying your compliance plans to incorporate ICD-10 verbiage, and then again, looking at our documentation as it is today to determine if we have enough specificity to support those ICD-10 codes. So we're going to be working with our vendors. Your staff hopefully is already contacting and working with your vendors to make sure that they can capture both ICD-10 and ICD-9 data, that you're sending test claims to your payers and those clearinghouses that you utilize so that we know once we start submitting claims in ICD-10 that they're going through clearly. everybody's concerned that once we start billing with ICD-10 in October, that we're going to have a delay in claim payments. And while that very much may be the case, we believe that the bigger backup is going to be that our smaller vendors, like our clearinghouses or our billing companies, are the ones who are going to stall our claims, not so much that the payers won't be able to process them in ICD-10. So doing some upfront work to make sure that your EHRs, your billing companies, your practice management system, your clearinghouses can all smoothly transmit and receive ICD-10 data will help eliminate any of that delay that might be caused come October. So like ICD-9, we're going to have a good bridge of communication between our healthcare providers and those helping in the coding department. So if they have questions on procedures, need help in specification, need help understanding some of the fracture nomenclature, those are all things that hopefully you'll be open to kind of help educate us as coders as ICD-10 is used. If you aren't already within your organization doing some type of dual coding, that's something that you might want to bring up to the powers that be. Basically, it's already about less than 5 months away. We should have our coding staff doing some coding in ICD-10 each week, not only to get familiar with the process and how those codes work, but more importantly to identify possible areas within the documentation where we might be missing specificity that we could capture. Now, there's a lot of talk about all these specific codes in ICD-10. That does not mean that there still aren't unspecified codes, and it doesn't mean that there won't be unspecified codes and that's the best code to use in certain situations. But what we don't want happening is your system picking, your EHR not having specific enough diagnosis codes listed, or not having a usable interface for you to select the specific diagnosis code you require, and that's forcing more things to go to an unspecified code. The other thing is Medicare has come out to say that for those codes that have laterality, they will not pay unspecified codes. So if there is a fracture code that has a right arm versus left arm, or whatever the anatomical position may be, if you try to build that laterality as unknown or unspecified, Medicare is not going to pay that claim. So it's not that, usually it's not because our documentation doesn't tell us that it's the right or the left, it's that our EHRs or our billing systems aren't doing a good job of pushing laterality or asking laterality questions when we are choosing diagnosis codes in our note. So the chapters are changing in ICD-9. It's kind of a little bit different for the coders more than the physicians. We're going from roughly 13,000 ICD-9 codes to close to 68,000 ICD-10 codes. We're also changing from 17 chapters to 21 chapters, basically just splitting out some of the organ systems into their own individual chapters rather than combination chapters. Our characters, our codes themselves are becoming longer. So we're moving from a maximum of 5 digits or characters out to 7 characters. Every code starts with a letter, and we use every letter except the letter U. For injury specifically, these are going to be grouped by the specific site and the type of injury. This is exactly how we group things now in ICD-9. So in ICD-10, we have an expanded injury codes, including those external causes and places of occurrence. We have greater specificity with laterality and granularity. For multiple bones, we have multiple sites in different areas or ends of the bone further defined that we